Aloha everyone, and thank you for joining the Hawaii Public Health Training Hui's September training, Implicit Racial Bias in Healthcare and Hawaii. Next slide, please. My name is Stephanie Moyer, and I'm the Community Initiatives and Training Coordinator for the Hawaii Public Health Institute. And other organizers of this training are Makamai Namahoe, our Contracts, Grants, and Operations Assistant, as well as the Hawaii Public Health Training Hui Steering Committee, which is made up of 14 different members from various organizations. Next slide. I want to acknowledge our sponsors and partners for this training, the Hawaii Public Health Training Hui, the Western Region Public Health Training Center, as well as the Public Health Learning Network. Next slide. Just to go over some Zoom housekeeping, for all questions, please utilize the chat box or questions and answers box located at the bottom of your screen. This webinar is being recorded and will be available on the Hawaii Public Health Training Hui's YouTube channel, as well as the Moodle course list. Next slide. For continuing education credits, we have been approved for 4 areas: Certified Health Education Specialist, Dietetics, Social Work, and CSAC. And this information will be shared with you when I share the PowerPoint, so you will have a chance to take note of the learning codes. Next slide. Learning outcomes for today's training define explicit and implicit bias, describe how implicit biases are formed, describe how implicit biases can impact provider-patient communication, as well as identify at least one thing that you can do to become aware of and/or change your implicit biases. Next slide. It is my honor to introduce you to our guest trainers for today. We first have Dr. Rebecca Delafield. Rebecca is an assistant professor with the Department of Native Hawaiian Health at the University of Hawaii John A. Burns School of Medicine. Her research interests include maternal and perinatal health, health and healthcare disparities impacting Native Hawaiian and other Pacific Islander communities, implicit racial bias, and community-based participatory research. She received her BA from Macalester College, majoring in sociology, completed her MPH in maternal and child health at the University of North Carolina at Chapel Hill, and received her doctorate in public health from the University of Hawaii at Manoa. Our second speaker today is Dr. Andrea Hermosura. Andrea is an assistant research professor with the Department of Native Hawaiian Health at the University of Hawaii John A. Burns School of Medicine and a licensed clinical psychologist at the Queens Medical Center, Family Medicine Clinic, Polimomi, and Paradigm Hawaii Counseling. Her research interests include perceived racism, implicit racial bias, health disparities experienced by Native Hawaiian and other Pacific Islanders, and community-based participatory research. She received her doctorate from the University of Hawaii at Manoa and completed her clinical internship from the VA Pacific Islands Healthcare System. So without further ado, I'd like to turn it over to Dr. Delafield.
Next slide, please. Mahalo, Stephanie, and thank you for having Dr. Hermosura and I speak today. It's a pleasure to be here. Here is an outline of the topics we're going to cover. We're going to start with some basic definitions so that we're all on the same page when we're talking about these issues. We're going to talk about implicit bias, how it's formed, healthcare research, looking at implicit bias, and then we're going to talk about Hawaii's context and some of the research conducted in Hawaii, just briefly, and we're going to spend quite a bit of time talking about interventions to manage bias. So this presentation on is on implicit racial bias, and we're going to talk about it and its relationship to racism. And so talking about racism can be difficult and emotional for many people for a multitude of reasons. And one of the challenges is that there's no standard education on racism for the general public. So, we're trying to start this conversation, but we don't really know where everybody is. Also, we were invited to do this presentation specifically as a response to the current national conversation on racism. So we want to acknowledge that we are going to have this discussion and that many of you took time out of your day to participate in this event. And some of you may be looking for more. And so we wanted to share this tool that's on the right hand of your screen as a way to, that's something to help you reflect on where you are in this journey. And also to say that we cannot, in this one presentation, take you through this whole process today. We're going to be talking specifically about implicit racial bias, just within this context that Andrea and I have kind of studied around the research that we've done on health disparities here in Hawaii. So addressing implicit racial bias and systemic racism is an ongoing and very deep process, which takes a lot of time and requires many different formats and many conversations. What we do hope is that today you'll build some awareness, maybe talk specifically and have information specifically about the context of Hawaii, and then we'll be able to share some tips that's about managing implicit racial bias that will help you progress from wherever you start. And so I wanted to just take a moment to read the quote that we're presenting here from Ijeoma Oluo, the author of So You Want to Talk About Race. The beauty of anti-racism is that you don't have to pretend to be free of racism to be an anti-racist. Anti-racism is the commitment to fight racism wherever you find it, including in yourself, and it's the only way forward. So that's kind of the context that we're bringing to this discussion today. Next slide. So Andrea is going to talk about definitions now, and then I'll be back in a few minutes.
So aloha, like Becky said earlier, thank you so much for allowing us to be here with all of you and to share the work that we've been doing and our passion around implicit racial bias. So this section is really to help us all be on the same page and to understand what we're referring to when we throw out different terms. So the first two concepts we're going to go over are race and ethnicity. Race, as we understand it, is socially constructed categorization based on skin color or appearance without any scientific foundation in biology. Whereas ethnicity is an identity often tied to people's culture or language, but it's also a product of social construction. And the primary example of ethnicity and how it's been socially constructed is that the only federally recognized ethnicity on the census is Hispanic and non-Hispanic. But Hispanic cultures are very highly heterogeneous and not specifically tied to language, culture, or place of origin. And so this quote is another quote that we wanted to point out by quotes, but race is a child of racism, not the father. So Dr. Kamara Jones defines race as a system of structuring opportunity and assigning value based on the social interpretation of how one looks or their race that unfairly disadvantages some individuals and communities while unfairly advantaging other individuals and communities. And doing this really saps the strength of the whole society through a waste of human resources. So on the right side of your screen, there was a special issue of National Geographic that came out that shows two twin sisters who were raised in the same household, attended the same schools, have the same families. But it's interesting that we want you to think about how they might be treated based on the way that they appear. And so in a lot of different situations, the twin who is darker complexion and looks more Black may not be able to reach her full potential because of the way that she looks. Dr. Kamara Jones also put together different levels of racism, and she defines it as a system rather than an individual character flaw, personal or moral failing, or psychiatric illness. And this is the way that we can start to have conversations, because we're no longer trying to divide the room into who's racist and who is not. And so it shows that we all have skin in the game to address different levels of racism. So the first level is structural racism, and they're features of our society, or of our social, political, and economic systems that support and perpetuate racism. It includes historical and contemporary policies, practices, norms, and values. Institutionalized racism is distinct from structural racism and refers to policies, practices, norms within an institution that leads to differential access to goods, services, and opportunities. Personally mediated or interpersonal racism is the one that most people are familiar with and are think of most often when we refer to racism, but that includes prejudices, bias, and discrimination. And then last is internalized racism, which is the acceptance by members of the stigmatized races of negative messages about their own abilities or intrinsic worth. And so these different levels make up the structure of racism and perpetuate the existence of racism within our society and community. So now that we've talked about different levels of racism, I'll be providing you with a few more definitions. And these, so biases may be explicit or implicit. Explicit biases are positive or negative attitudes or stereotypes towards a person, thing, or group that a person is aware of and is under conscious control. Whereas implicit biases are positive or negative attitudes or stereotypes towards a person, thing, or group that are outside of our conscious awareness. So we all have biases, and they influence how we think and can impact how we behave. Biases are a part of natural cognitive processing that helps humans process millions of bits of information. We all have an innumerable number of biases, and they're influenced by our experience and context. So you can't count them, and they're not exactly the same for everyone, but there are attitudes and stereotypes that are widely shared throughout societies or communities. And this is how certain gender, age, and race biases are established. Today, we're going to be talking specifically about implicit racial bias, but race or ethnicity is just one example of a single concept. And keep in mind that we're just beginning to research how these biases impact our society, and more specifically, the field of health and medicine. So implicit racial biases are explicit and implicit attitudes or stereotypes associated with specific racial groups that is rooted in racism. So racism is the mechanism by which associations that pair stereotypes and attitudes with certain or specific racial or ethnic groups are learned. We are aware that racism is a reality in our society, probably now more than ever, and can impact the assumptions and prejudices people have about the abilities, motives, and intentions of others according to their race or ethnicity, as well as discrimination or how people are treated because of their racial biases. We also know that racial bias race is a social construct, and that the color of your skin has nothing to do with your ability to lead, your character, or how you conduct yourself.
Thank you, Andrea. So I'm going to talk about how racial implicit biases are formed. Next slide. So as Andrea mentioned, biases are a part of natural cognitive processing that helps humans process information. And they're formed through learned associations. So attitudes and associations are thought to develop through what's called classical conditioning, or the repeated pairing between conditioned stimuli and unconditioned stimuli. So here on the slide, I have dusting equals cookies, which makes no sense to anybody, right? It's not something that you would typically think in your mind or associate together. But what happens in the context of classical conditioning is that if you were to do some dusting and then eat a cookie, and then you did some more dusting, the next time you dusted, you ate a cookie, and then, you know, for months on end, whenever you dusted, you ate that same cookie. Then the next time you dusted, you might crave that cookie, right? You might want specifically that cookie, or expect to, or if you're eating a cookie, the converse, you might you might feel like dusting. But what that is that's a paired association of two unrelated constructs, right? So this happens all the time in our lives and we don't really notice it. So when did red start to mean something to us? Next slide. So if we're drivers, red is automatically paired with the idea of stopping the car, right? And green is also paired with go. And that's not something that we need to think about anymore as mature drivers. It's something that we automatically understand as we're approaching an intersection. If I see a red light, I'm going to stop. So it becomes an automatic response. So first it's learned. So implicit biases are learned. They're not inherent. They're not something you're born with. But then once it's learned, it's mastered and it becomes automatic. So if I were to approach an intersection and a blue light showed up on the traffic light, I would not know what to do, right? We'd stop, it would be very confusing. And that's what takes me to the next slide, where I'm gonna talk about what's called System 1 and System 2. So these systems were kind of described by a psychologist named Daniel Kahneman. And this information comes from his book, Thinking Fast and Slow. So implicit associations are fast and unconscious. They're what happens when those learned associations are paired together and mastered, and they're part of your System 1 thinking. So Dr. Kahneman, what he did was he basically, he won a Nobel Prize for explaining why human beings, though they're rational people, do irrational things. And so how he explained it kind of generally, this is a big, this is a very brief overview, but is that people have the System 1 that's involved in unconscious processing. It operates automatically and is extremely fast. So again, it's that red light. If you see it, you stop. If the light turns green, you go. You don't have to put any conscious effort into it. There's also a second system, but that is called the rational thinking system, System 2. And it's the conscious processing. So that's the system that would kick in if that light at the intersection were to turn blue, right? That's the system would be like, I don't know, I have not mastered this pairing. There's no pairing with this blue light. What do I do now? So it's used for mental tasks that require a lot of concentration. So for example, completing a job application or something. But it is characterized by being taking a lot of effort, being very slow and logical and fairly lazy, like it doesn't want to kick in. So what happens is for most of our time, our conscious processing is relying on system 1. And so that's why how the types of associations that we learned and become implicit and are processed is very, very important. Next slide, please. So how does society impact our biases? So messages that assign a value, going back to some of the definitions that Andrea talked about, right? So if they assign a value or a characteristic to unrelated traits like skin color, sex, or class, they're learned through conditioning and then they're reinforced through systems. So some examples of common stereotypes based on these categories is association between males and science. And for class, like poor and lazy. And for Black men, violence. Right? So those are common stereotypes that unfortunately we see in our society. These messages get absorbed and may be in opposition to our conscious values. They may be in opposition to our beliefs and in opposition to our own self-interest and sense of self. Regardless, these unconscious biases can be formed and can influence behavior. So even if we are not totally conscious of the fact that we are behaving differently, when we have these messages infused in our environments that send information or send messages about sexism, classism, or racism, the systems that those systems manufacture and perpetuate this. So if you look on the right-hand side of the screen, if we're in an environment that has racism and starts to demonstrate through policies and practices, norms, and values, certain people are inferior to others based on a skin color, those associations get learned by people. And those learned associations can create mental biases, right? Implicit biases, explicit biases even. And that can lead to discrimination, which is a behavior. And behaviors that discriminate against people of certain races then perpetuate the environment of racism. Next slide, please. So that was the kind of short information about implicit biases and the way that they're formed. So just to review, biases are part of a natural cognitive processing that helps humans kind of sort through all these millions of bits of information that they're getting every day. They are learned, though. They're learned through these they're formed through these learned associations. They're not inherent to us. And implicit biases are unconscious and may not align with our declared beliefs or stances. But within systems where there is racism or systems of structured advantage and disadvantage based on characteristics like race or other things, these associations that are learned and automatic can be damaging. So they may lead us to discriminate against others. And one thing that we need to keep in mind is that for that system one to slow down, it takes some effort. So in situations where people are stressed or demanding circumstances, they're more likely to be activated compared to when they're in a relaxed state. So one of the reasons that I can talk about implicit bias and the fact that it's getting this attention is that we have the ability to measure it. And so the next slide, go to the next slide, please, Andrea, is going to talk about implicit racial bias in healthcare. So Dr. Hermosura and I come to this conversation through our work as health disparities researchers and our common interest in looking at these issues through our work to improve health equity for Native Hawaiians and other Pacific Islander communities. So just to be clear, like our approach is through that lens, meaning that the information that we're gleaning is all kind of filtered through that perspective. And these issues are complex and multifactorial, but they're important to address. And so we're very kind of pleased that we can talk to you about them today. So one of the tools that is used to measure implicit bias is called the implicit association test. Now there are other tools, but this is the most common. And it was developed by researchers, Dr. Anthony Greenwald and Dr. Masrin Banerjee and other colleagues at Harvard in 1998. It's a computer administered sorting task. And you're asked to sort either through faces or words that represent, like faces or representational images, or words. And then you sort those to different targets. And it's a response latency assessment, which means that the time it takes to do each assessment is compared to each other. So if you go slower for one sorting task than the other, they calculate that difference, and that generates a score for this particular measure. So the limitation of this, one of the limitations, is that it only measures the relative strength of associations. So it can only really look at two different concepts. It can't really provide any kind of magnitude of difference. So it's just, do you have a preference for this or this? But we don't know like how strong that preference is relative to other kinds of things. It also often includes an explicit bias measure when you take these tests. And I'm not sure, but many of you may have already taken some of these. There are many, next slide, sorry, Andrea. There are many implicit bias tests that are available publicly through a website called Project Implicit. And you can see here on the screen to the right-hand side of your screen a list of various tests. And so when we talk about implicit racial bias, we need to be very specific because there's all sorts of implicit biases that are formed in the same way through these learned associations. So this site is publicly available. We put the website up there. And research resulting from this site that's looked at the particularly the Black-White attitudes test. So this is looking at race of Black versus race of white. Showed that for 70% of the respondents, which were, were over 1 million people who have taken this test, that for over 70%, or around 70% of them, sorry, showed some implicit association with white faces and positive attitudes. So we're compared to Black faces. So that's described as kind of a pro-white attitude. So a strong pro-white preference was also observed across all the racial groups, except for people who identified as Black in the studies that have been done. So this is just an image to show you what a computer screen would look like in case you haven't taken this test. The screen would have, the instructions would have you put your fingers on the E key and the I key, representing left or right side of the screen. And then you'd sort the stimuli that comes into the middle. In this instance, it's a picture, to one of the different sides. So if this is a Black face, then you'd sort it to the left side, right? And then you might get another stimuli, and if it's this word, you'd sort it to this stimuli, you'd sort it to the side where it would fit. So sickening is a bad experience, and so then you'd sort it to the left again. And there's other stimuli that would come up. So maybe joy would come up to the middle of your screen, and you'd sort it to the right. And then other exemplars of the different groups, and you'd sort and sort and sort. And eventually you take a test where the pairings are switched. So you'd sort good with African Americans and bad with European Americans. And then the time that you take to do the sorting would be compared for the different pairings. And the interpretation of the test is, if you pair something quickly, if you do the sorting task quickly, that means you have a stronger implicit association between those two things. You with me? So the research into implicit racial bias in healthcare has shown, by looking specifically at this Black-White attitudes test, that there is pro-white implicit racial bias among healthcare professionals that is similar to the bias level of bias found in the whiter population. So what that means is that specifically they looked at physicians held a kind of an equivalent level of pro-white bias compared to those millions of the general population that took the test from the site. So with that established, the next research question that people wanted to know is, okay, so if people are holding these pro-white implicit bias, what does that mean in terms of the way that they treat patients? And so this is a literature review from 2017 that looked specifically, oh, sorry, Andrea, are you advancing the slide? Sorry. That looked at literature at studies that examined the relationship between those implicit association test scores and then certain health or healthcare outcomes. And the main finding of this paper, and this is one table from it, is that that greater implicit pro-white bias on the part of providers was consistently associated with poorer patient-provider communication with their minority populations. And patient-provider communication was measured in terms of things like verbal dominance, negative affect, which means the provider seemed cold or hostile to the patient or to the observer, and then poor patient evaluation, so patient was less satisfied with care. The other interesting thing about this particular study is that there's more consistent associations found between levels of bias and the outcome when the research is conducted in a setting that's real world, meaning it's not something where the providers were tested for their implicit bias and then given like a sheet of paper that talks about a case study and asked them for their recommendation. This real world setting was one where they were directly observed dealing with and helping patients. So that really makes sense and is consistent with the things we know about implicit bias, in the sense that, as we said, implicit biases are activated more in stressful and demanding conditions. So if you're relaxed and you're just taking a sheet of paper and you have that time to kind of stop and think and get that system 2 working, and really contemplate what your response will be, versus if you're seeing a patient and you have other patients waiting, how if that implicit bias might be more active in those kind of situations. So there's definitely more research that's needed to explore implicit racial bias, and to understand potential modifiers and confounders on the effect of implicit bias in terms of healthcare and health outcomes. But we also think that there's need for research around strategies aimed at reducing bias and improving patient and provider communication. Next slide, please. So just to summarize, implicit racial bias may contribute to health disparities and healthcare quality and outcomes. And implicit negative bias impacts patient-provider communication and relationships. So, for example, verbal dominance, negative affect, and then slower dialogue with the patient. It may also influence diagnosis and treatment decisions. So there have been some studies that show that higher implicit bias, more pro-white bias has led to differential treatment between Black and white patients for different things. So that's just to summarize. And so, next slide, please. I'm gonna continue for a little while. I hope everybody's doing okay, and talk about context. So context is critical for understanding implicit biases because they're formed through these learned associations, as we said. But because Hawaii is a very racially and ethnically diverse state with its high proportion of people who describe themselves as multiracial, Hawaii has been often described as like a melting pot and positioned as a place by some to appear void of racism. But there are clear examples of racism in Hawaii, and both in our contemporary and our historical context. So again, remember, I'm talking about racism in this wider systemic view, right? So Hawaii has a complex, thank you for advancing, Andrea, has a complex collection of identities. So the context is different. Our racial and ethnic diversity is unlike other states, and the way that we perceive and experience and communicate and identify about our racial and ethnic, our own race and ethnicity is fairly unique. But there are clear racial inequities in multiple sectors in Hawaii, and these contemporary realities, these differences that we're seeing today, are rooted and connected to historical experiences of oppression. So while the context may be different, racism still operates here and has some of the same basic elements. So we know this because of individual reports of racism. We know this because of cases of explicit discrimination that have been reported. And we also see that similar to experiences of or reports on health for Black and Indigenous people of color in other places, we see disparities by race and ethnicity in terms of various outcomes for our community. So higher incarceration rates for Native Hawaiians in Hawaii, lower life expectancy, higher infant mortality, and more recently, very salient now is the disparities we're seeing for Pacific Islanders in terms of COVID-19 cases. So this is a model of systems of inequality, and this is from an article that was written by author's name is Nixon, and it's just been published in 2019. And we use this model again to emphasize the systemic forces that shape inequalities and expand the conception of racism beyond just this individual level. So the author here in this paper states that these systems of inequality do not reflect individual behavior of, again, like good or bad people. They're society level norms or structures that distribute advantage and disadvantage regardless of whether a person wants it or is aware of it. So the relevance of the impact of these positions will vary according to the context that they're in. So the systems of inequality identified here in this slide include like white, non-white, and that's the focus of these talks, but also recognize these other ways that people are identified in our society. So settler and then versus indigenous, settler colonialism versus indigenous is one, but also in terms of sexuality and gender identity, etc. So different systems of inequality will matter more or less in different contexts and depending on the intersections with other patterns of inequality. So for example, well, like what I said, like while we're talking about racism within Hawaii, there's also this element of settler colonialism that's very salient and important to understand in terms of power and the way that it overlaps, that those identities overlap and intersect with someone's race, the way that they're racially identified. The other important thing that Nixon points out is experiences of oppression on one side of this structure, or what she calls the coin. So if you're on the privilege side of it with a certain identity, it doesn't mean that the experiences of oppression negate the positions of privilege in other areas. So that was an important thing, I think, to point out. So briefly, power is something else that we need to talk about. And positions of power, privilege on the coin are also tied to power. So power at the interpersonal level is something that is continually shifting and often being negotiated. So for example, at the individual level, a person from a racialized group, for example, may have a medical or graduate degree and have high earnings and have wealth and privilege as a result of that. But they may walk into a store or a school and be condescended to because of existing stereotypes in our community. That same person may also, the next, an hour later, walk into their place of work and be recognized as an authority by the people who work there and have the ability to assign tasks to different people and distribute advantages to employees. Then they may go back home and be a leader in their family or, active in their community and respected in a certain way. So in that way, you can see how power and privilege and identities and the salience of those identities shift throughout at the individual level. But what we're talking about in terms of the systemic racism is power at the institutional level and privilege at this larger community and societal level, which does not shift rapidly. And they're deeply entrenched patterns. And those things have contributed to the messages and the assignments of value that we're seeing. And so, for example, early deaths among minority groups that are influenced by these social determinants that were shaped by historical policies of oppression, subjugation, and contemporary stances of neglect, for example. These factors have an influence on greater mortality, lower income, and those changes and the power to make changes at these larger levels require a lot of effort and do not shift as so easily. So it's critical to, next slide, please. Sorry, Andrea. Okay. It's critical to unpack the ways in which racism underlies the current power structures here with regard, and I'm meaning in Hawaii, with regard to the social position of racial and ethnic groups. So looking at the broad population of patterns that we see here and the wealth and positions of power that exist in Hawaii, they're largely occupied by white and Japanese Americans, and to some extent Chinese Americans. But these patterns of race are not specific, are not attached to specific abilities of those racial groups, right? There's nothing that would connect us to believe that some races have the ability to lead or to accumulate wealth or a cultural affinity to education or health more than others. Their results, these differences in our society are a result of these legacies of racism and shaped by the evolution of our common history since Western contact. So those examples are like colonization, military occupation, global trade, contemporary geopolitics, etc. And these legacies are something that we want to take a few minutes to reflect on for specifically the groups that Andrea and I have studied, which is Native Hawaiian and Pacific Islanders, but specifically Micronesians, which is a racialized identity in Hawaii that typically does not refer to the full geography of communities from the region of Micronesia, but actually in Hawaii most often refer to people who are coming from 3 different communities three different island nations, or have ties to three different island nations that are under compacts of free association agreements with the United States. So though we'll focus on Native Hawaiian Pacific Islander experiences, we don't mean to diminish the reality of racism towards Black Americans or other groups here in Hawaii, but we do want to highlight the context of these histories that we're familiar with. And so when we are talking about this, really, you know, I'm not a historian, but what I want to show, what we want to demonstrate in talking about this is how opportunities have been structured and value has been assigned. And through those actions or these events, there's messages that are spread through our communities about the value of Native Hawaiians or the value of Micronesians here. And so the history of Native Hawaiians as the indigenous people of Hawaii is distinct from some of the other Pacific Islander groups, but they've experienced traumas that have diminished their status in the island. Their status in the islands, and marginalized them in multiple areas of our current society. So these events have contributed to shaping the narratives about these two groups in our state. And even through many of the assaults in the past years, there are still, even though it's been a long time, there are still repercussions of these events. So we think about the illegal overthrow, the US supported occupation, and the effects that had in terms of the political power of Native Hawaiians, who were then had less just population to enact any to gain political momentum. The annexation of Hawaii, and then also the banning of the language in school and other things that were done to kind of tamp or diminish cultural practices, right? Or even outlaw or ban them. And then in addition, there was this live fire training and bombing of Kaho'olawe. And so Kaho'olawe, the location it was said was perfect for military training to fight what was referred to as the new kind of enemy in the Pacific. So over the course of World War II and 45 years that would follow, the island was riddled with bullets and mortars and bombs that would deplete the topsoil remaining on the island that had already been eroded too. So although there have been, again, significant steps towards revitalization of the Hawaiian language and culture for the last 50 years, the attitudes and stereotypes that have been kind of established through some of those actions remain and are ingrained in some of the narratives that are perpetuated in our society. So through this historical lens, you can see how opportunities are structured or disadvantaged Native Hawaiians in their own land. Next slide, please. So again, for Micronesians, when you think about structuring opportunity and assigning value, I can't go through the whole history, which includes long histories of colonialism, but you can see here from the US involvement in 1947, many of the islands in Micronesia became trust territories of the US. And under that trust territory agreement, the US was responsible to make ample provision for political, economic, social, and educational development of the inhabitants. The engagement of these islands in these spaces during World War II were extremely valuable to the US. And so one of the reasons they entered the trust territory was to maintain this military advantage. Yet at the same time, so when they took this military advantage, they said they were going to develop some of these islands. They tested 67 nuclear devices in the Marshall Islands, which required the removal of people from home islands and resulted in environmental devastation that had severe impacts on the health of residents and on the environment which they depended on. So this is all happening after the US and the rest of the world had seen the devastation of the bombing of Hiroshima and the kind of devastation it could cause. And then there's a quote here that's been reportedly stated by Henry Kissinger, who was at the time National Security Advisor, but also a former Secretary of State. There are only 90,000 of them. Who gives a damn? And there's actually a PBS special that talks, is actually quotes that. But so that's kind of one of the historical events, but there have been more. So the trust territories failed to provide some of the things that they said in terms of developing infrastructure for education and health. And so through over a course of several years, eventually the islands of the Marshall Islands, the Federated States of Micronesia, and Palau became independent, but also agreed to be in a compact of free association with the United States, which gave the United States exclusive military control of those islands. So they were allowed to come to the United States as a way to access some of those things that they were promised. But in 1996, were disqualified from specifically Medicaid, and so could no longer attain that support for health services, even though many of the citizens actually qualified by income for that service. And so some of you may be aware of this because you're working in communities, but these are just examples of the messages that these communities are getting and that other people are getting about these communities that show a lower value, and then also structure opportunity like access to healthcare. And there's a recent quote by Mayor Caldwell in August in reference specifically to the disparities we're seeing in our Pacific Island communities, who are largely represented by some of these citizens affiliated with the Compact of Free Association states. And he said, in some ways, I think we forgot about this community, which I think says a lot about the way that those historical events have continued and are perpetuated today. So next slide, please. So do these patterns of explicit actions and policies demonstrate less value for these communities? And how does that, how is that reflected in the health status of people who are living here? And I put up a number of different measures, including health disparities that we see in Native Hawaiians and other Pacific Islanders, but also disparities that we see in education, income, housing, and also, as mentioned before, incarceration and the rates of COVID. And we cannot say, because there's not enough research to say that experiences of discrimination or implicit or explicit bias are responsible for these, but we do think they factor in, and we cannot rule out that these have an impact on those outcomes. So research, next slide, please. Research on implicit racial bias in Hawaii is kind of an area that Andrea and I are looking at, and we're going to present some of our studies, but other people have looked at this too, but we're going to just share what we've done. We have multiple projects going on right now, and the one that I'm going to share with the results is the one that I've done for my dissertation work, which was completed in 2019. And so we'll talk about actually too the development of the implicit association test, and then one of the studies that piloted a set of those tests. And again, we have some research that's ongoing. So implicit association tests were tailored for Hawaii's communities. So we developed 8 IATs to examine implicit association between the following groups that were not available through any public site, right? So Project Implicit has done many different groups, but they've never done these particular groups. Professor Levinson, Justin Levinson at UH Law School has, but that was not a publicly available test. And so we looked at some both different pairings or different groups, and then also we looked at, we were kind of specifically interested in healthcare. So those are some of the differences between his work and ours. So we looked at Native Hawaiians compared to Caucasians, Native Hawaiians compared to Japanese Americans, Micronesians compared to Caucasians, and Micronesians compared to Japanese Americans. And we looked at both attitudes, so these good or bad kind of affiliations. So that was some of the terms that you saw that we referenced back when we were showing the work from Project Implicit, but also stereotypes. Next slide, please. So why would we pick white and Japanese American? So I went over this a little bit before, but there is no single like dominant group here in Hawaii. So when we talk about racism and we talk about privilege and like advantage and disadvantage, we actually need to look at it in a little bit different lens. And so when we think about the groups that are highest income, highest socioeconomic status by per capita income, we see that whites, Japanese, Americans, and Okinawans are among the highest. And we also see that reflected in a lot of the leadership, both in the private industry and in our public leaders. And then we see that 6% of Japanese live in poverty compared to 16% of Native Hawaiians and over 50% of Marshallese, who's I think their average income in the report that I saw that was published in 2018 was about $32,000 a year. So those are broad aggregated numbers, right? So next slide, please. So implicit bias among OB-GYNs. So this is the study that I did for my dissertation. The research question was, is there an implicit preference among OB-GYNs that favors whites over Micronesians? So this was one of those studies that was just looking at whether or not this is a thing here in Hawaii. Is implicit bias something that we should be concerned about when looking at health disparities? Because we didn't have any data on it. So this was done in response to disparities that were reported in maternal outcomes specifically from Micronesian patients. And so we decided to do this measurement of implicit bias with this group. And what we found, again, still planning to get this published, so it has not been peer reviewed yet. But what we found is that we had 29 people take the Micronesian white IATs. 21 completed it, the Micronesian Japanese IATs. Only the Micronesian white IAT test scores reached the significance level that was, reached a level of significance. So we think that's related to the number of people that took it. So the sample for the other comparison was too small. And what we found was that there was a slight preference for white over Micronesian. So there was this pro-white preference. It was not at the magnitude that we'd seen in some of the other studies that looked at the Black versus white IAT. And so the other thing that we found was that there are some moderate positive correlations between IAT measures with age and length of time working and residing in Hawaii. So that is consistent with some of the things we know about implicit bias, right? So if we say it's part of this messaging that gets kind of deeply ingrained in people, it would make sense that people who have been exposed to the messages longer may have impacted more. So there are more studies underway to kind of look more closely at the way that these IATs are operating. But what this study shows is that there is some indication that exposure to some of the common narratives are influencing implicit or unconscious attitudes. So thank you very much for your time. I hope you all are doing okay. At this point, I'm going to mute myself and Andrea is going to present too.
Okay, so thank you, Becky, for talking about the context of implicit racial bias in Hawaii and the research that we've been working on. Now I'm going to be talking about managing our implicit biases in particular. So the good news is that implicit biases can be managed, addressed, and reversed through interventions. So explicit, like Becky alluded to earlier, our explicit biases and the systems in which they operate can change relatively quickly and is relatively context independent. So it's not based on rooted and ingrained narratives that we've heard and seen through our systems, policies, norms, and values. But implicit biases systems is highly contextual and only changes in an enduring way after considerable time, effort, and/or intensity of experience. So you need to be intentional and have goal-directed effort over time in order to change these implicit biases because they're ingrained in the systems in which we operate. And implicit biases are likened to deeply entrenched habits like smoking or eating or exercise habits that you want to change, but they're developed through socialization experiences. So that's maybe where they're different. And so we, implicit bias trainings like this is necessary, but in itself not sufficient for eliminating biases. You really need to do the work and be intentional about eliminating biases that are bothersome or that are getting in the way. So there is evidence to show that some implicit bias training programs are more effective than others. And the ones that are more effective tend to incorporate bias awareness. And so that's why Dr. Delafield and I have been developing implicit association tests so that we can have an assessment available to identify or help people identify whether or not they have biases towards certain populations or groups, in particular Native Hawaiians and Micronesians, that they want to change. And effective implicit bias training programs also transfer evidence-based bias reduction and mitigation strategies to their consumers. And so it really is, the reason why we spent a lot of this presentation talking about the context of Hawaii is that we really need to learn about the different contexts that activate the biases that we have, and then how to replace the bias responses with responses that reflect your goal. So if you don't want to have a preference, for example, for whites compared to Blacks or Native Hawaiians or Micronesians, then how can you change your behaviors or the associations that you've had over time? We've learned over time to be consistent with where you want to act or how you want to behave. So in order to change your implicit racial biases, you must be aware of your biases. So sometimes we don't even know that we have certain biases towards certain groups. And so it's important to do things like the implicit association tests to see whether or not you do have those biases and you want to change them. And typically you need to have some concern about the consequences of your biases. So are you noticing, or are you worried about how your biases might be impacting the treatment that you're recommending, or your patient-provider communication, or even your interactions with colleagues or students? It's important for people who want to change their implicit racial biases to be concerned about the potential consequences. And then you need to be motivated to try to eliminate them. And so these 3 factors are required according to the prejudice habit model that was put out there by Devine and colleagues in 2012, and talks about evidence-based strategies to reduce or eliminate implicit racial biases. And so I'm going to talk more specifically about 6 different strategies that you can use to reduce implicit biases. The first is mindfulness, or the intentional use of attention, is how I learned, or how I was taught to define it. And because biases are more likely to be activated in stressful situations, mindfulness can be a strategy you can use to reduce stress and increase your intentional use of your attention. So different mindfulness strategies include focused or diaphragmatic breathing, guided imagery, or progressive muscle relaxation. The second strategy is contact with the counter-stereotypic other. And so this is when you're going to use your imagery or your imagination to identify in detail counter-stereotypic others. So they can be abstract, or like smart Black people, or famous or non-famous racial group. And it makes positive exemplars salient and accessible. So if there is a stereotype, for example, that Black people are violent, which there is, then you could think about different Black people who are not dangerous that you've encountered and have had positive interactions with. The third strategy is individuation. And so trying not to provide stereotypic inferences about a group as a whole. So looking at people of those racial groups as individual members with personal attributes that can be unique and are typically unique. So they say that there's more in-group differences than between group differences, and that can help us to look at individuals rather than, and their qualities, rather than associating certain qualities with how they appear or what they look like. And then next is perspective taking. So considering experiences from the point of view of the person being stereotyped. So if you weren't, if you didn't get a job promotion, for example, because of the way that you looked, how would you feel about that? And so kind of putting yourself into the shoes of the person who's being stereotyped can help you understand better what it might be like to be in that different situation. You can also read or watch content that discusses those experiences or directly interacting with people from that group. And by doing that, you increase psychological closeness. So like the more that you can empathize with the people or with other people who are experiencing discrimination because of the way they look, it might be a way to decrease group-based evaluations. And then stereotype replacement, which is recognizing that a response is based on stereotypes. So if you respond to a question or you ask a question about someone based on a stereotype, catching that early, then being able to label that response as stereotypical, reflecting on why that response occurred. So where did that question come from? Did you hear other people ask those questions in similar ways? And then considering how the biased response could be avoided in the future. And so it's really like taking a step back and taking time to reflect on different interactions and different questions or ideas or thoughts that came up during your conversation, thinking about an alternative option, and then replacing your response with an unbiased response the next time that you interact with that person or the next time that you engage in a similar type of activity. And then last is increasing opportunities for contact. So seeking opportunities to engage in positive interactions with our group members. And so we're more likely to spend time with people who are a part of our in-group. And so if there is a group that you're less familiar with, creating opportunities to have positive interactions with them. And by doing that, then you change the cognitive representations that you've learned through the narratives in society or the media or in education that we've learned, the images that we've had about those groups, so that it can change the evaluations we make. So it's interesting because we're more likely to have strong associations about a racial group that we don't have much interaction with. And so because if we have interactions with different people, then we're more likely to change the cognitive representations we have about that group. Okay, so now I'm going to talk about institutional strategies that can be helpful to reduce implicit racial bias. So there was a really great article that came out by Dr. Kamara Jones in 2018. And she talks about different anti-racism strategies. And I'm going to focus on the ones that are related to institutions and things that you can do on a larger scale, rather than the six strategies that I talked about earlier. And so the first one is focused on organizational excellence, or recognizing the mechanisms of racism in our structures, policies, practices, norms, and values, which are different elements of decision making. So paying particular attention to the absence of, so who is at the table of decision-making bodies, who is not, what is on the agenda and what is not, and really paying attention to who is not there and what is not being discussed, and then asking the question, how is racism operating here? And so it really takes institutions who are open to hearing honest feedback and with a willingness to change, to ask these really difficult questions and to look into their policies and practices, maybe for specific examples of how different groups have been provided with opportunities, while other groups may have been provided, had unfair advantage or disadvantage in your institution. And then the next two strategies are around education and development and communication and dissemination. So in education and development, it's asking the question, like, how can we support the training of public health professionals and researchers around issues of race, racism, and anti-racism at educational institutions of all levels? So do we start talking about this when people are in college, or do we talk about it when they're in preschool? And how do you adjust the curriculum that you're sharing so that they're age appropriate and you're sharing ideas, because it's affecting all of us at all areas, at all levels of our lives. How does an effective anti-racism curriculum look? And so really stepping back and asking these hard questions and having people at the table who understand this work, and exploring different ways to put together an effective anti-racism curriculum together. And then finally, communication and dissemination. So how can we support the naming of racism in all public and private spaces? What tools and strategies are needed to start community conversations on racism? And so it's really like knowing that racism exists, but how do we name it? And how do we have these kinds of conversations that we're having today? And what do we need to equip ourselves to start having these conversations on a broader level, maybe even with people who aren't open to the idea of it yet or aren't ready to talk about it? And so how do we create those safe spaces for people to share wherever they are, even if it isn't where we think they should be? So mahalo nui loa for joining us again today. We want to thank the Queen's Health System's Native Hawaiian Health Initiative and the Department of Native Hawaiian Health at the John A. Burns School of Medicine, who both provided support for our work and our publication. And these are the references that we included in our presentation. And so mahalo, Steph and Makamai, for inviting us here today, and mahalo to all of you for spending your afternoon with us. We look forward to our discussion.
Thank you,
Thank you so much, Andrea and Becky, for this wonderful presentation. So just as a reminder, if anyone does have any questions, please feel free to pop them into the chat. You know, I think, as you just mentioned, how it's very important for different organizations or groups out there to really look at who's at the table, who's not. And I think that's a discussion that I myself have been having with groups that I'm associated with. And there's just more rich discussions that can happen when you start partnering with folks that maybe are not your typical partners that you would normally partner with on different projects. So I think that's really important to hear. One question that I had was, you know, what advice do you folks have for those that might be on the call who would want to have these discussions at work, or how can they start this discussion with their supervisors?
Andrea, do you want to field that one, or?
Yeah, sure. So I think sometimes it's when I encounter those kinds of situations, it depends on where the supervisor is, I guess I would ask. Like, are they open to these kinds of conversations? Are they more hesitant to have them? Because it really, your approach might need to be tailored depending on what kind of response you might get. So if it's someone that, like Becky and I have been looking for allies a lot, and Becky actually facilitated an interdisciplinary implicit racial bias like consortium of different people at UH Manoa doing this work already. And our like supervisor is very good, like very involved and understanding about this work, but we've also encountered others who are not. And so it's really like asking questions about their perspectives, like where does it come from, and recognizing that these narratives, we're all subject to them, and we all experience them. So it's not necessarily like a them versus me or us kind of interaction. It's more like, how do we all address these systems of racism that we're all a part of together? And so maybe if you approach it in that way, like a collaborative, like trying to understand their perspectives versus trying to educate them and change their mind, like right in those moments, it could be more effective. Becky, you want to add to that?
No, I think that's really good, because I think, like we started out saying, there's such a spectrum of where people are in terms of their willingness to engage. And I've have friends and colleagues who, you know, they have people who are at their in the leadership of their organizations or their workplaces that are, you know, on board and responsive. Then I have people who, even after attempts to try to address some of these things, the information is kind of, you know, not percolating at all. And people can get very defensive because this is an emotional thing. It can surprise people that they don't know, you know, that there are these elements operating, or people can reject what you're saying because, stop me anytime, Andrea, but like reject what you're saying as a response to it. So, you know, you want to keep yourself sane. So I think finding, you know, other people just at least to soundboard off, like, because sometimes you can feel like, oh, I brought this up. This is what I was perceiving at work and I felt uncomfortable. So I went to my boss, but then they said this. So finding other people you can talk to and getting perspectives on things is helpful, and would help you kind of assess, like, in that discussion, oh, where are people within this environment that I'm working in? And so, yeah, I mean, that's all I got for you.
Thank you. No, that's good. And I think just to follow up, it's a similar question that we have in the chat. It's, you know, how do you recommend approaching this when there are concerns within HR?
So that one I would send to Amrita.
I know. I was just thinking, I wish Amrita was here. There's a woman named Amrita Malik who is a lawyer by training, but she talks about HR policies and what's acceptable and not acceptable, and then how to address it. I think that does add a layer of complexity on top of the already complex issues that you're trying to address. So I'm so sorry. I don't know how to answer that exactly, but I think it, like I told Steph, it really depends, I think, on the individual situation and what's going on. And that's what's really hard about having these discussions. Like, there's no this like blanket way of addressing a lot of these issues.
And I think, you know, the hard part is that to get people comfortable in a place where you're going to grow within that kind of framework that we use, to kind of rely on that framework that we introduced at the beginning, you need to create a safe space where people can be honest with themselves and with other people in a way. And sometimes that safe space is only like 2 people, right? And hopefully you get it to grow. But the law, the way that it works is that there are kind of hard, fast rules in some ways, or at least that's how it's interpreted. So it kind of can collide with these efforts. So I think there are people who are more experienced in looking at that and how you develop, because there are protections, right, against specific types of discrimination and that kind of thing. So hopefully maybe Stephanie, your next talk can be something more, people with more expertise in that area.
Great, thank you. So I do just want to acknowledge a comment that came into the chat, and I'll go ahead and read it off. So it says, my parents were immigrants and distrusted others, especially those who were different, so they kept us isolated. When I was younger, I parroted, the racist language, as I did not know anything else, as I think many others do. As I got older and more independent, I saw that what my parents said did not align with what I observed in real life, and realized they were wrong. I wish so many others would be able to come to the realizations that I have, but it is highly fraught for many. So thank you for sharing that personal story.
Yeah, thank you. That's really, really great that you had that opportunity. And I think Yeah, different people are at different places on the continuum. And sometimes the messages are so deeply ingrained that it's the norm. And so it's even harder, I think, to step back and recognize them.
So we do have another question. So it says, do you have a training or consulting curriculum that includes the local Native Hawaiian and Micronesian IAT ways to address individual and group or organization biases?
So the sad answer is no. And it's really caught us off guard because actually in the past several months, we've been requested to do these talks, which were initiated, through us just presenting our research on implicit bias that we did. And through that, knowing that, if we're going to talk about implicit bias because people hadn't been exposed to a lot of this information, we have to kind of give a background, and feeling responsible to talk about racism since we were looking at racial implicit bias. So we kind of backed ourselves into this and still are working on, developing and completing the studies so that we have confidence in the test that we've developed. And so, we are in touch with other people who are doing some of this work, but at this point, as far as I'm aware of, it's very much kind of piecemeal. And so I know our institution is trying to get some stuff developed. I know that, there's certain kind of curriculums being worked on for addressing health equity that would include some of these things. But in terms of specifically like a local training on implicit bias for the public, I don't have that. I don't have information about anything like that right now.
Thank you. And I think a follow-up to the question that I just asked is, can work or maybe issues be referred to you folks if people are looking for, and I hope I'm interpreting this correctly, but if there are requests for trainings, can we contact you folks?
Yes, I want to say yes, you can contact us. And I think like we did with Steph and Waka, like we just talked about what your expectations are, who the population is that we're going to be presenting to, because we've done different ways, like different types of things. So this is more of a presentation on our work and like our understanding of implicit bias in healthcare and in Hawaii. But we've also done like more self-reflective type of stuff, like asking people to kind of think about where they are on the spectrum, on the continuum that Becky showed earlier, and then how does it affect their work and patient-provider interactions, those kinds of things. So we've kind of done a little bit of lots of different things at this point. So yes, and we're both very, very busy. So I'm going to apologize in advance that we'd have to find something that works for all of us for it to happen. Becky, you want to take back what I said? I'm just joking.
No. But yeah, I think that, kind of one of the things that's helpful to us understanding either whether we could say yes or no to anything is if you kind of have your bigger vision and your goal in mind. And, we try to help people work through that too. But that's really a question that some people struggle with, right? Like, especially now in the context where we're seeing all this movement and like organizations coming out with statements and stuff, like in terms of, addressing anti-racism or being in support of Black Lives Matter. Like, I think one of the things is, but where do you want to go? Like, how deep of an investment is this, and is it feasible really for that? So it would take a little bit of, we would ask like some reflection on your part, whoever would be the asking person. And we've done, different things, and we're constantly evolving, right, Andrea? Like what we feel comfortable with, what we think is working. So if you have any feedback for us, we would love to hear it. Like, because that always improves and helps us understand how we're coming across, or if we express something in a way that, didn't come through very well, or could be improved on.
It does look like a lot of the questions coming in are regarding trainings or other opportunities for training. So do you folks know, besides yourselves, of any other individuals or organizations that are doing trainings around racism?
I know people who have talked about it, but I don't know training specific to racism, or I might just be drawing a blank. But if I do, or we hear about it, we definitely contact you, Stephanie, and let you know so you could send that information out. But I'm assuming you're talking, so there's a ton of stuff on the internet, right? Like so many agencies have got like implicit bias stuff and anti-racism things. So, you know, Dr. Kamara Jones has done some great work with the American Public Health Association. But in terms, I think what people are asking is in terms of contextualizing those things to Hawaii, which is why I think Andrea and I have been tapped so much, is because we tailored those tests to this context and we talk about, you know, those things. So for that specific thing, I'm less sure. Professor Levinson, he's written books and stuff about implicit bias. That's I think not all of it, but some of it is specific to Hawaii, but it's within the framework of criminal justice system, I think. So, but he's doing stuff, and then we're working with this collaborative, but we were doing it for a research and education kind of platform rather than actually like in-person training.
Thank you. So I'm not sure, Becky and Andrea, if your, can you remind me if your contact information was on the slides? And no, okay. So I'm happy to be the middleman. So if anybody on the webinar today does have any questions or would like to be in contact with our trainers today, please feel free to email me and I will put my email into the chat box. We do still have just a few more minutes before we need to wrap up. So any other questions from the audience? And maybe while I let you guys think about any other questions, Becky and Andrea, do you have any last minute thoughts that you want to leave with our attendees?
Just to say thank you for attending this, and I hope there were at least things that kind of helped you think and reflect and can help you move along. Because I think there's, you know, one of the things that Andrea mentioned is that you have to have motivation in order to start to manage the bias. And like for me, just logging on to something that talks about implicit bias specifically is one of those ways where you have that motivation. So that's already a step towards working on managing bias, and that we all have it. And this coming through this process for me is been kind of life-changing in a way, being able to kind of understand in a different way kind of who I am and what my influences were, and then how to work through things. And it's a process, and so we really appreciate your taking the time and starting this with us.
And I would like to second what Becky's saying. I mean, I think this requires a lot of self-reflection and patience with yourself and kindness towards others. Like, I really think the change happens when you can meet somebody where they're at, right? And as providers, we talk about that a lot. Like, I'm not trying to push people to do something that they're not ready to do, but kind of letting them come to you so that you can create that safe space to have those difficult conversations. And so we're just grateful for you, Steph and Maka, for creating this safe space for us to have these conversations, and for inviting us to share with all of you. So thank you, everyone.
Mahalo.
Great, thank you so much. So just want to say a big mahalo to Andrea and Becky for being our trainers today, and mahalo to all of you who joined live on our webinar. I do have a few reminders since this is our first training on Moodle. Thank you for your patience, first of all, as we have kind of worked through the kinks of transitioning over to Moodle. As you may have seen when you logged into Moodle and went into the training for today, there are restrictions listed on the next steps. So the quiz, the evaluation, as well as your certificate. Now that we are almost done with the webinar, you will see once you go back into your account that the restriction will be lifted on the quiz. So you will then be able to take the quiz, and as you kind of check off each of those, the restrictions will be lifted onto the next item. I do hope that you find this process exciting, as you have immediate access to the evaluation as well as your certificate. But please don't hesitate to reach out to me if you have any questions regarding anything that I just mentioned. Again, I want to thank you for attending today, and oh, I forgot to remind you to save the date for our next HUI training, which is on Friday, October 16th, with Dr. Joy Tanji, and her training is going to be on Beyond Resistance, Understanding Ambivalence in Treatment. Again, mahalo, and we look forward to seeing you all on an upcoming training.